like the choreo-asteroid movements, dystonia, chorea, and ataxia, the hyperapneic respiration or hyperapneic breathing, the CNS finding, that is disconjugate movements of the eyes and the cranial nerve pulses, the clinical presentation of the Japanese encephalitis, the clinical presentation of the Japanese encephalitis, the history taking of the patient is having its very great importance due to the incubation period and the history of the bite of the mosquito in disease endemic zones. So history taking, 6 to 8 days incubation period, and there are prodromal symptoms: fever, malaise, vomiting, diarrhea, headache, and altered mental status. So prodromal to altered mental status, it may vary from the altered mental status or altered mental sensorium may vary from the subtle change in behavior to the coma. So the history of the Japanese encephalitis patient is having prodromal, then altered mental sensorium, which may range from the subtle change in behavior to the coma. The physical appearance of the patient or the physical examination of the patient of the Japanese encephalitis is generalized weakness, the clinical findings or the physical findings of the patient of Japanese encephalitis: hypertonia, hyperreflexia, including the pathological reflexes, and there are papilledema, in 10% cases which are having neurological manifestations. So papilledema and the cranial nerve palsies, and disconjugate movements in 35% cases which are having the neurological picture of the Japanese encephalitis. The extrapyramidal Parkinsonian symptoms, the extrapyramidal Parkinsonian symptoms in form of the chorea, choreoathetoid movements, dystonia. So these are the physical findings during physical examination in a patient of Japanese encephalitis. So the diagnosis. This is a very, very important part of the Japanese encephalitis infection, which can save the life of the patient. The early diagnosis or after the subside of the febrile illness, after the first week or in the end of first week and start of second week, there are frank neurological manifestations. So the diagnosis part of the Japanese encephalitis can save the life of the patient, and the mortality rate, which is more than 35% patients in untreated patients of the underdeveloped and developing countries, is brought less than 5% in ICU setup hospitals. So the diagnosis is ELISA. The ELISA captures the Japanese encephalitis specific antibody IgM. The IgM is increased in the CSF and serum. The ELISA captures the IgM after 4 days in CSF, that is cerebrospinal fluid, and it captures the IgM in serum on 7th day. Serum. So the ELISA captures the IgM, the virus specific antibodies, in CSF on 4th day and in serum on 7th day of the disease. Isolation of the virus. The demonstration of the virus or the genetic material of the virus inside the infected person's cells is very, very difficult. It is very difficult due to low viremia of the Japanese encephalitis and transient viremia. In case of dengue and other viral encephalitis, virus can be demonstrated inside the infected person, but in case of Japanese encephalitis, it is very, very difficult to identify and demonstrate the virus due to low viremia and transient viremia. The virus remains very short time inside the person, and the viremia, that is the number of viruses, is very, very low. So demonstration of the virus is very, very difficult. The lumbar puncture, the findings of the CSF, increased protein and number of cells is more than 150 cells, and the sugar is normal. So in CSF finding of the Japanese encephalitis, increased protein more than 900 milligrams, cells number more than 150, or it may range from 50 to 150 also. Sugar level in the CSF is normal. The complete blood count, CBC of the infected patient is having initial leukocytosis or moderate leukocytosis, CBC moderate leukocytosis, followed by relative leukopenia. About 15% cases, especially children, are having thrombocytopenia also. There is hyponatremia and hypokalemia, so decreased calcium, decreased potassium and decreased sodium. When there is decreased concentration of potassium, the prognosis is very, very poor. So it is related to poor prognosis. So the CBC is having a picture of moderate leukocytosis initially, followed by leukopenia, relative leukopenia. 15% of the patients of Japanese encephalitis are having thrombocytopenia, decreased potassium and decreased sodium concentration. The decreased or below normal concentration of the potassium is having very poor prognosis. The other poor prognostic features are the patients who are having poor prognosis, the age less than 10 years and low circulating immunoglobulins in the CSF and high concentration of virus or the viral genetic material in CSF, all are having very, very poor prognosis. The MRI and CT scan of the brain. The MRI and CT scan, the MRI is very sensitive. There are changes in density in thalamus, subthalamus, hypothalamus, metathalamus and the epithalamus. Changes in putamen, changes in basal ganglia and pons, medulla and midbrain. So there are changes in diencephalon, that is thalamus, epithalamus, metathalamus, subthalamus and hypothalamus. The putamen, the basal ganglia parts, the pons, the medulla and cerebellum. These are parts of the cerebrum. These are the deep nuclei of the cerebrum. So density changes in diencephalon, putamen, basal ganglia, pons, medulla, and cerebellum. There may be also some hemorrhagic parts in these all areas of the brain, and hyperintensity is seen in T2 weighing MRI, especially in pons, putamen, basal ganglia, and thalamus. So MRI is very sensitive investigation for the Japanese encephalitis infected person. EEG. The EEG, electroencephalogram, EEG, there is the continue delta wave slowing. So continuously there is delta wave slowness in the patients of Japanese encephalitis, and there is abnormal theta wave. But the EEG changes are not related to the severity of the Japanese encephalitis. The treatment. Treatment is entirely supportive treatment. And the airway maintenance, oxygen saturation of the blood, the control of seizures, the control of intracranial tension, ICT, and the control of mean arterial pressure, the control of the seizures and ICT are the mainstay of the treatment of the Japanese encephalitis. The seizures are more common in children less than 10 years. Increased intracranial pressure and severe headache are more common in the adults. The mannitol is used. Mannitol is used to decrease the intracranial pressure and the pressure inside the subarachnoid space. The subarachnoid space of the brain is having the blood vessels, major blood vessels of the brain supplying the all parts of the brain parenchyma. So maintenance of the pressure inside the subarachnoid space is having great importance in the management of the Japanese encephalitis patients. The electrolyte balance. The electrolyte especially the potassium, the hyponatremia and hypokalemia are seen frequently in the patients of the Japanese encephalitis. The hypokalemia is having very poor prognosis in the patients of the Japanese encephalitis. The sodium and the fluid management there are no specific antiviral treatment there are no specific antiviral drugs for the Japanese encephalitis virus. But in recent researches, it has been proved that the shuramine, the thiocarbamate is having antiviral role in Japanese encephalitis.